didn't pick up. So let me double check that it is being recorded. Thank you for checking, because I did hit that earlier. Let me just repeat this one slide because it is critical. The earlier slides, 1 through 20, you can review on your own. It's just basically an overview of the gastroesophageal reflux disease and the nature of acid splashback into the esophagus. One normal HCl is going to do some damage if it continues to splash back, and you'll basically, there are some behavioral management techniques, but acid neutralization with a variety of over-the-counter medications that you're familiar with in the name of Alka-Seltzer, Gelusil, Maalox, Rolaids, and Tums. These are direct buffers, essentially. There are some H2 receptor antagonists still available over the counter. We're mostly concerned about the proton pump inhibitors that directly inhibit the exchange of acid or hydrogen or protons that can inhibit the formation of HCl in the stomach. And there are quite a few: Prilosec to Nexium, the conversion we're talking about tonight, Prevacid, Protonix, and Nasifex would be the primary competitors. A crowded landscape of proton pump inhibitors. And again, this slide, I'll tell you again, is important because it speaks to the uncertainty, the slippery slope of moving from GERD symptoms to Barrett's esophagus or early metaplasia of the esophagus, into high-grade dysplasia of Barrett's esophagus, into cancer of the esophagus, adenocarcinoma. And we just don't know who's going to move down this slope because symptoms are not consistent with the severity or progression of disease. You can have quite mild GERD or not even know you have it, and go on to develop all of these metaplastic conditions and then cancer, and vice versa, get quite severe and have no progression of the disease. And we do not do endoscopy routinely in the United States, whereas we do colonoscopy routinely. So again, thank you, students, for pointing out that Tenzin, this wasn't being recorded. Anna asks, when it comes to Barrett's, I thought this was more of a complication of chronic alcohol abuse, but are all patients with GERD at risk? Yes, all patients with GERD are at risk for developing Barrett's, high-grade dysplasia, and cancer. The alcohol abuse component is because alcohol itself can be metaplastic. As you've been probably reading in the paper, that we're now finding that no amount of alcohol is considered beneficial, that any amount of alcohol consumption is associated with health risks, cardiovascular disease, and potentially certain cancers. In this case, Anna Sampson is speaking to the risk of the effects of alcohol on the tissue of the esophagus that can facilitate Barrett's and beyond. But today we're talking more about just GERD, independent of alcohol per se, although alcohol certainly makes it worse. So thank you for pointing that out. Did I miss any questions? No. Okay. So again, this is an important slide. You need to recall this for the exam, because I'm going to come back to this as I explain to you how Nexium used this uncertainty to its advantage in its competitive positioning and the conversion of Prilosec, the off-patent drug at the time, moving to Nexium, the branded and patented drug that was premium priced. So, erosive esophagitis complications, you can see here some of the symptoms don't match the severity of the erosive disease, as I mentioned. You can have strictures and adhesions that can cause some complications, narrowing of the esophagus, obviously that would be bad. Barrett's esophagus, columnar metaplasia associated with the development of cancer of the esophagus, adenocarcinoma. So those are the obvious slippery slope complications of this pathway. Acid damages the lining of the esophagus, causes chronic esophagitis. It can heal in a metaplastic process, developing abnormal columnar cells that replace the squamous cells. This specialized intestinal metaplasia can progress to dysplasia and adenocarcinoma, as you see in the illustration here. That's what it looks like on endoscopy. And here's what Barrett's esophagus looks like as it progresses into more serious intestinal metaplasia under histology. Endoscopy to the left, histology to the right. and ultimately cancer of the esophagus, which is often fatal and has very poor response to standard therapy, standard of care therapy. And I'm not familiar with any gene therapy or CAR T therapy or targeted PD-1 or PD-L1 agents that are targeting esophageal cancer. So it has very poor current therapeutics. So it's to be avoided. How prevalent is Barrett's esophagus endoscopy? Up to 12% of symptomatic GERD. Less than 1% of patients without GERD. So there's some relationship to symptoms, but not huge. You can clearly still have Barrett's esophagus and not have any clear symptomatology. If you look at the incidence over time when this work was being done, published in 2005, relative to melanoma, cancer of the prostate, breast, lung, and colorectal cancer, esophageal adenocarcinoma going through the roof. If you look at the rate ratio from relative to 1975, for some reason. And similarly, the mortality and incidence are correlated and going up linearly as well, as you see in this slide, from 75 to 2000, pretty well a linear incidence. Can somebody tell me again the difference between incidence and prevalence? Incidence rate is what? Important you know this.
Is incidence rate of occurrence and prevalence is how widespread the issue is?
Essentially, who was that?
Serge?
Yeah, Serge, essentially that's true. Incidence is typically reported as the number per 100 population, and prevalence is the cumulative amount that could occur over a period of time. So just something you need to remember as you move forward. New esophageal cancer cases and mortality. So over 15,000, almost 16,000 new cases, with about 14,000 deaths per year, which I think is pretty consistent. Incidence would be new cases. Yes, that's true. That year's incidence per 100,000. Age-adjusted incidence rate for esophageal adenocarcinoma. You can see the data with regard to the most recent epoch, 92 to 96 in this case. It seems to be getting worse. Why? I don't know. We're getting older as a population, getting heavier, more prone to complications and frequency. What are some of the attributable risk factors for esophageal cancer? If you've ever smoked, if you've got a high BMI, if you've got GERD symptoms, you don't consume complex carbohydrates like fruits and vegetables, and obviously if you have one or more of these, your risk goes up significantly. Proportion of disease attributed to given risk factors. Now, the screening question for Barrett's esophagus, according to the American College of Gastroenterology and the American Gastrological Association, with the Barrett's group, it's all over the map. They suggest that it be individualized. If you don't have GERD symptoms, clearly no, across the board. But if you do have GERD symptoms, there's not a clear yes. And therefore, the Preventative Health Service Task Force doesn't recommend it. And it's considered not cost effective because only 5% of esophageal cancer cases undergoing resection occur in patients with known Barrett's. So who do you screen? Do you screen those with GERD, older folks, men over women? Who and how? So if you look at the relative risk benefit or the cost on the y-axis, you can see how, no screening or surveillance has a certain quality adjusted life here as a health economics measure. You can see that the cost goes up dramatically when you screen with surveillance. And so the calculation is that it doesn't pay, essentially, to screen. Tessa says, I know sometimes the endoscopy are done in the same appointment. Why is that not done more often to increase screening? Yeah, it's a fair point. I've wondered myself that same question. Unless you're symptomatic, that's just not going to happen today. But I think it should, especially since you conserve the anesthesia and you only go through that one time. And maybe it needs to be reserved for older patients, I don't know, over a certain age, but currently the US Preventive Service Task Force is not recommending it. And half of probably health insurance companies don't want to cover both. Yeah, that's no doubt part of the reason, but it is not, and therefore there's a real uncertainty, unlike colonoscopy, which should be done every 10 years without polyps. If you have polyps, much more frequently, 3 to 5 years, depending upon your family history. So who do you screen? What are the, there's a large pool of patients with chronic GERD, there's millions, yet there are few cases of adenocarcinomas, actually more like 15,000. So that's how the numbers don't tumble. But proton pump inhibitors reduce the incidence of dysplasia in Barrett's esophagus. You can see the data here is quite clear on the y-axis. The dysplasia rate with and without proton pump inhibitor therapy is significantly improved with PPI therapy, as you see in the blue line. Is Cologuard able to catch erosive? No, it's not. And Cologuard, I'm not sure where that is in terms of recommendations, just how effective that is for colorectal cancer.
You have the slides set for
What's
marketing.
that? Say again? Yeah, Cologuard is not for erosive esophagus. Isn't Cologuard for colon screening? Blood in the stool? I think you're mixing your metaphors here. We're talking about the esophagus, not the colon. I was making reference to colonoscopies because there are guidelines and insurance companies do pay for colonoscopies, but they don't pay for endoscopies. Endoscopies are what are used to review the esophagus and the stomach. Okay, Anna? All right. So what do we know about proton pump inhibitors? They give you good symptom control. They can do some healing of the esophagus. They certainly decrease acid. They can reduce the columnar changes in the squamous cells and potentially even regress a bit of the Barrett's epithelium. Proton pump inhibitors in Barrett's esophagus, they may decrease dysplasia risk, and they're simple to use. They're relatively safe agents. So there's no real risk in using them. Even primary care doctors were prescribing them routinely for patients with GERD. Yvonne.
Hi, doctor. I have a question because I had an experience once. I was experiencing acid reflux, and I went and got over-the-counter medication. I think it was omeprazole at the time. But when I went to when I was able to finally see the doctor, they weren't able to have me do any tests because I was on omeprazole. With the marketing, for omeprazole and other GERD medication, how is it that they make sure that patients are picking up the over-the-counter medication and it's the correct thing for them, the correct, purchase?
So I'm not exactly sure of your question, but let me address what I think I'm hearing.
Okay.
Go back in. Empiric therapy, basically. They're not going to send you to I didn't hear what you were suffering from. Was it heartburn or GERD?
I think it was just like acid coming back up. When I finally saw the doctor and she was like, "Oh, you've been taking omeprazole. I can't do any test." Like she couldn't do any. I don't remember what the test she was trying to do, but she couldn't.
Measure the pH of the gastric fluid. Were you seeing a gastroenterologist?
It was a GP.
Well, they wouldn't have done that test. So In any event, if you're taking a proton pump inhibitor for a while, you're going to get healing, especially for a young person. You typically would not send them in for an endoscopy. It's expensive. If a doctor prescribes it, it probably will be covered if you have symptoms, but it's not done as routine screening. What guidelines would have to be met for insurance to cover an endoscopy so a patient can check for cancer? Well, I'm not sure if guidelines would have to be met, because right now there are no guidelines for endoscopy, other than if you've got symptoms, a doctor will send you for an endoscopy and you can get screened and the insurance will cover that because the doctor ordered it for a symptom. You may or may not have serious disease. We're talking about screening the entire population of, 100 million people, or whatever number of people are over age, let's say 55. Right now, colonoscopy age and recommendation is 45. So what age would you start to do endoscopies, and at what cost relative to the 15,000 cases a year? So you see there's a cost benefit ratio that comes into play. So the FDA approved Nexium, which is S-omeprazole, and that for the healing of erosive esophagitis and the maintenance of that healing. Also for NSAID-induced gastric ulcers, etc. And there were these stomach wars going on. Chronic conditions, acid neutralizers are being used extensively. You can see some of the pictures here. I'm sure many of you have these in your medicine cabinets, or your parents do. And by the late 90s, antacid sales in the US were $7 billion, with Merck in the lead. The proton pump inhibitor Prilosec was the best-selling drug in the world. Sales of $5 billion a year every year. I don't know how many years Prilosec had patent protection after it was developed, because I think it's 20 years, but you lose about 10 years in development. So let's say it had patent protection for 10 years. That's, in my mathematics, higher math, 5 times 10 or $50 billion in revenue. And it was far and away not just the leading drug in the world at the time, supplanted later on by the cholesterol lowering agents, which had even higher sales. But it was by far AstraZeneca's biggest drug. When they were concerned about the loss of patent and the conversion to Nexium, you can only imagine how important this was to AstraZeneca's future. Even TAP Pharmaceuticals, producing a Me-Too Prevacid, was doing $3 billion a year. This is an extremely lucrative marketplace. So we're going to talk about some stereochemistry. And not to frighten you, we're not going back into organic chemistry, but enough to say that sometimes only one isomer is active against the disease. There's the stereochemistry, you may remember, turns plain polarized light in 2 directions. Nobel Prizes were won. You can turn, your hands are mirror images, they're not the same. And so there's the right and the left, and they turn plain polarized, organic molecules turn plain polarized light, shine through a spectrum to the right or the left. And one or the other will be more biologically active. S-omeprazole, I believe, was the left-turning stereoisomer of the racemic mixture of Prilosec. So it's important for you to understand that the discussion for tonight, the only difference between Nexium, S-omeprazole, and Prilosec is the difference between a racemic mixture, Prilosec of the right and left, S and L, and in S-omeprazole's case, the purified enantiomer of the racemate. Okay, does everybody follow me? That's the only difference, and that's significant, but it's important you understand this. And
Can you repeat that, please?
yeah, let me see if I have a picture of it. We'll come back to that. So Prilosec, the drug that was going off patent by AstraZeneca, that was making $5 billion a year for probably over a decade, is a stereoisomer. It contains the right and left isomers of the racemic mixture. Think back to your organic chemistry. So organic molecules, biological molecules turn plain polarized light in two directions, right or left. And when they're purified and separated, you get esomeprazole, which is taken out of the mixture. And so essentially esomeprazole is the enantiomer, the isomer that turns plain polarized light, I believe, to the left. Can somebody check that? Is it left or right? Esomeprazole. I think it's left. Could be wrong. It doesn't matter. The point is, it's the purified enantiomer left. Thank you, Amber. So that's a little bit of organic chemistry, but it allowed them to extend the patent for many drugs. They didn't extend the patent of Prilosec. They got a completely new approval. So it was a new molecule. But many times the purified stereoisomer or the enantiomer changes absorption, distribution, metabolism, excretion. This is pharmacokinetics, right? How the drug is basically absorbed, distributed, metabolized, and excreted. People are raising hands. Okay. Hold on a second. Who's raised their hand to speak up?
I did.
Yeah.
Just like to go back over what we just went over, like with the stereoisomers. So does that mean like most of the drugs that we've gone over in class have had multiple isomers, like during the developmental phase, and there was only like one of the isomers that worked in order for it to like actually work, or is that just like for certain drugs?
For certain drugs.
For certain drugs.
None of the drugs that we went over this semester that I'm aware of have been produced as purified enantiomers.
Okay.
But it's a good question. I'll give you a list here, I think. And so we'll come back to that in a second, because I want to show you there are many that have been developed this way, but not all, not the ones we've discussed this semester. This is the only one I think that has done this. And you can see how doctors are confused by this. I'm not sure I get it. How can compounds be the same but different? Think of dextromethorphan and levomethorphan. This is a good example. As identical twins. They're not the same, but they look the same, except one is the mirror image, the right hand of the other. One is benign, dextromethorphan. One is strong enough, it's a potent narcotic analgesic, levomethorphan. Dextromethorphan is used over the counter as a cough suppressant, powerful cough suppressant, right? But you don't have the opioid effects of dextromethorphan. It's the same thing. It's the stereo. It's the mirror image of a very potent opioid. So you can see how powerfully different stereoisomers are from each other. And there are many, and here's the picture of dextro and levomethorphan. Dextro, again, is available OTC, 5, 10, 15 milligrams in a dose, suppress a bad cough, no opioid effects. Levomethorphan is a narcotic analgesic. But this whole business of stereochemistry in action, trifenadine or Seldane, you can see, and I'll give you citalopram versus Celexa. There are many, and billions were poured into the development of stereoisomers in the 90s, and you can see a few more examples of this here. Redux, which was withdrawn, it was a stereoisomer. Levaquin, the antibiotic. Carvedilol, an important beta blocker. Clearly Nexium. Albuterol, a beta agonist. And Lexapro, an important antidepressant. Lunesta for insomnia. Nuvigil. So you can see there have been quite a few, to your earlier question, that have been developed. Difference between single enantiomers and racemates are likely to become the focus for aggressive promotion at the same time. And regulatory authorities need to be provided with good evidence and good clinical trials about the implications of these chiral switches. So I see a few questions here. When is a proton pump inhibitor used? When a proton is used, what is the change in pH of the stomach from before and after? I don't know the specific numbers, but it's dramatic. You know, the pH, somebody can look up the pH change on use of proton pump inhibitor and let us know, but it's pretty significant. Okay. So esomeprazole, the left turning enantiomer of the racemic mixture of Prilosec, which was going off patent, was compared in terms of its ability to treat patients with erosive esophagitis in randomized controlled trials. 425 patients, 163 centers, compared once daily dose of 40 milligrams of the S against 20 milligrams of the mixture. And you can see the healing rates are 81.7 versus 68.7. Esomeprazole versus the racemic, Prilosec. At 8 weeks, 94% versus 84%. 10-point difference, significant. Therefore, the conclusion of this study, published in the American Journal of Gastroenterology in 2001, was that esomeprazole, Nexium, demonstrates significantly greater efficacy than Prilosec, omeprazole. Tolerability and safety were comparable. So this engendered an awful lot of interest in the industry, and ultimately, when it was ultimately approved, you could see the advertising of they took the color of the old Nexium, Prilosec, and basically made Nexium the new purple pill. It actually was a very important marketing ploy, and you can see the advertising that ensued. But here's the important point, and this is the key takeaway, one of the two key takeaways from tonight's lecture you'll need to know, that Nexium or esomeprazole, the purified enantiomer, because of its structure, its esomeprazole structure, from the mixture, a greater proportion of Nexium is metabolized more slowly via the cytochrome P450 3A4 enzyme, the membrane enzyme, than by the faster 2C19. Unmetabolized Nexium, therefore, is more bioavailable to bind to the proton pump, inhibiting secretion. So you see, this is the pharmacodynamic reason that the purified esomeprazole was potentially more effective than the stereoisomer Prilosec, omeprazole. Again, because it is more slowly metabolized, therefore more bioavailable. Okay, you have to know this. And to demonstrate that, this chart shows that time course on the y-axis, the mean plasma concentration, that Nexium 40 in the dark purple, certainly compared to omeprazole at 20 mg, is much more bioavailable plasma concentration in nanomoles per liter. And you say, well, isn't that just double dose omeprazole? Well, no, because even the 20 milligrams of Nexium, 20 right here, was greater than omeprazole 20 by itself, the lighter purple versus the gray. So this is demonstration, proof positive, that Nexium either 20 or 40 was significantly more bioavailable than Prilosec, omeprazole at the standard 20 milligram dose. Because, again, it's extruded more slowly through the metabolic pathway, therefore more bioavailable. And so anytime studies were published that looked at esomeprazole, Nexium, versus any other proton pump inhibitor at erosive esophagitis healing at 8 weeks, on average, there was about a 10% benefit in healing of erosive esophagitis, which is a precursor to Barrett's and cancer of the esophagus. And you can see the range here, but all of these gastroenterologist thought leaders basically published studies that showed you got about a 10% benefit of the purified stereoisomer. And so we sometimes talk about the NNT, or the number needed to treat. And the LA grade is the severity, grade D worse than grade A. And you can see that you only needed to treat 8 patients with esomeprazole versus any other proton pump inhibitor, including omeprazole, Prilosec, to avoid one bad outcome. That's what the number needed to treat means. How many need to treat to avoid a bad outcome? As you go up to the less severe forms of erosive esophagitis, you need to treat more. But when you speak to a gastroenterologist and you say, you don't really know who's going to become the worst patient, right? We just showed you that slippery slope earlier. That basically, because of the uncertainty principle here, you know that you only need to treat 8, 14, or now 33, 50 to the lesser grades. But as patients get into the worst grades and are more prone to cancer, the esophagus, you only need to treat 8 to 14 patients, on average about 10 or 12 patients, to avoid one bad outcome. Consistent with what I show you here as the 10% benefit of esomeprazole in the healing of erosive esophagitis. And the clinical trials generally supported that. Here you see no significant difference between 20 and 20. There were significant differences in this study between 20 Nexium and 20 Prilosec. But certainly 40-20 produced a significant difference each time. And the direct-to-consumer advertising was robust and persistent in those days. Heals acid reflux, you'd want proof, and now your doctor has that proof. Medical studies prove Nexium heals better than other leading prescription medicines. That's the 10%. Remember, they call Nexium the healing purple pill, pulling the branding forward. Brilliant branding. Call your doctor today. Because untreated, the damage could get worse. And nobody knows who's going down that slope. Because basically, I should have put that slide in again here. Let me just go back to it at the very beginning. What I want you to recall, when I ran an advisory board at the pre-launch of gastroenterologists, pre-launch meeting for around the country of leading gastroenterologists, and asked them, as well as payers from insurance companies were at the meeting. So, dear Dr. Gastroenterologist, if you don't know who's going to go down this slippery slope based upon symptomatology, doesn't really tell you who's going to get bad Barrett's esophagus, erosive esophagitis, and adenocarcinoma. And you know that there's a 10% benefit, that the number needed to treat for most patients is about 1 in 10. How could you not prescribe Nexium? Yes, it's more expensive. It's branded for a few dollars a pill, over 10 cents a pill, whatever it is, for the generic. But given that we've just shown you that there's about a 10% benefit, how could you not prescribe the one that you know is better? And virtually unanimously, they all said, yes, we would have to prescribe Nexium because we just don't know who's going to go down the slippery slope. Based upon what you've told us, what you showed us is the clinical study data that demonstrates a 10% benefit. If we had endoscoped everybody, maybe you would never have to use a drug that was branded and more expensive. Now, today it's over the counter and it's cheap. But at the time, this was dollars per pill versus pennies per pill. Nexium versus Prilosec. But if I'm telling you, dear Dr. Gastroenterologist, that you're going to prevent one bad outcome, meaning a cancer, in patients as they go down that slope, and you don't know who's going down that slope, how can you ethically not do that? Boom, home run strategy. And that's the point of this lecture. But understanding the pharmacological differences was fundamental to understanding the efficacy difference, 10%, the number needed to treat, 1 in 10, based upon the slower metabolism and the increased bioavailability, and the unknown risk of adenocarcinoma. Those factors put together made Nexium one of the best-selling drugs in the world. In 2010, sales of 6.3 billion, just on tour. And so AstraZeneca was quite pleased. Obviously, they thought that the strategy had to do with the stereoisomer story, the elegance of the chemistry. Not exactly. Had to do with the implications of the purified stereoisomer and its bioavailability increase, and therefore the improved number needed to treat. And, you know, the sales were quite significant over the years. but it was considered the most successful US launch ever at the time. On the annual business review, even more significant than the Vioxx launch, the Viagra launch, Advair Discus for COPD, etc. And it was a strategy that I drove with AstraZeneca at the time, the one I just showed you specifically relative to building on the efficacy, the NNT, the metabolic profile, the increased bioavailability because of the stereoisomer and the fact that you just don't know who's going down that slope. After a single dose of proton pump will raise gastric pH from 2 to 6. Terrific. Almost neutral. 7.0 will be neutral. So students, I hope you found that interesting. Certainly was a successful medical marketing strategy. Let me know, tell me now, do you think this was effective? Do you think this was slippery? What's your view? Anyone? Najma thinks it was effective considering it was the second best-selling 2010. Yeah, it clearly was successful. And it was a blockbuster. And Nexium had whatever period of time it had exclusivity. If it was doing $6 billion in a year, I don't know if that was true throughout its sales, but potentially, if that were true, $60 billion, it even exceeded the Prilosec patent years. It was a very successful program, but it was built upon an understanding of the pharmacology and getting that those insights into the head of gastroenterologists and making them believe that given the uncertainty, slippery slope, you had no ethical choice. Any other comments? Was Nexium the most successful case of stereochemistry? Yeah, it was. I know you mentioned the 90s. This was done, but why were providers not aware of the stereochemistry and what it can do for drugs? Not all drugs lend themselves to that separation, depending upon their three-dimensional profile. Is Nexium still successful in current times? Yeah, but it's over the counter now. It's not promoted per se like it was. And I'm sure it brings in significant sales, but it's not AstraZeneca sales anymore. I don't believe. Maybe they still hold. I don't really know who makes over the counter esomeprazole. Maybe it's still AstraZeneca. I'm not sure. Do most companies check for stereochemistry changes now? I'm sure they're all screening for it. There have been enough successes that it's certainly a relatively straightforward way to, was this just a patent extension? Was it fair to compare 40 milligrams of esomeprazole to 20 milligrams of omeprazole, or was that just a sleight of hand? I did show you that 20 versus 20, even esomeprazole was better, but not as much as 40. But yes, stereochemistry came of age. And I'm sure companies screen, because it's a lot easier to develop a purified stereoisomer than it is to come up with an entirely new compound and make $50 billion. Well, that's the end of the lecture, students, and that's the end of the lecture series. I hope you enjoyed listening to these and participating as much as I have. I always find it interesting to hear what students have to say. You all know how to reach me in my email and so forth if you have any questions. Again, I will post the final exam on the Canvas shortly before 7 next Tuesday. You won't find any surprises, I promise. Whatever I told you was important, you need to know from each lecture is exactly what I'm going to ask you on the exam. You're all quite welcome. I'm glad you were all here, and it was my pleasure. Again, I'll be on I'm having this foot surgery on Friday. I may not be on screen if I'm still laid up, But I will be there live in case there are any critical questions. And I'm glad you all enjoyed it. So thanks so much and be well. Good luck to all of you.
Thank you, Professor.
Good luck
Well-
with your surgery.
Thank
Yeah.
you all.
Thank you.